TopMedTalk.
Welcome to TopMedTalk here at Anesthesiology 2024. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell, your host of TopMedTalk, and some of our listeners may realize that I'm also Vice President of Clinical Quality for NorthStar Anesthesia. It's the other hat that I wear. So today we wanted to catch up with the NorthStar Anesthesia leadership team and dive a little bit more into what we are as an organization and what's really important to us and how we support anesthesia management and delivery here in the U.S. So it is with great pleasure that I introduce our next guest. We have Adam Spiegel, who is our Chief Executive Officer. Hello, Adam.
Thanks for having me, Desiree.
Yeah, again and again. You've been on the show. You've been in the hot seat several times, Adam. So thanks for coming back and chatting with us.
Always happy to see you.
Yeah. And then Josh Lumley, who's our Chief Quality Officer, Dr. Josh Lumley.
Yes, yeah.
And actually my partner in crime.
Totally. I actually work for Desiree. No one knows this, but Desiree is the boss at the Office of Clinical Quality.
Well, I think our TopMedTalk listeners would know that because I'm also the boss here when it comes to the podcast. And then new to the show is our Chief Operating Officer, Meagan Barkett. Meagan, I'm so glad we had a chance to sit down now.
You know I love to chat
I
with
know
Desiree.
you do.
I love it.
It's good. It's good. Well, I really wanted to start off and talk about what NorthStar is and what services we deliver here in the U.S. So, Adam, if you wouldn't mind kicking us off, tell us a little bit more about NorthStar.
Sure. So we're a large practice management company. We operate in 26 states, over 300 locations, and we have a sponsor. It's a company called Cranemere. They're long-term capital partners, and they really saw the practice management space as a place where what really matters to be successful in this is to have a very long-term view of the business. And that isn't being served particularly well by short-term capital like private equity or venture capital. It's not being really done well by public companies either. So large insurers aren't necessarily the ones that should be owning lots of physician practices. So it felt like an interesting space for long-term capital, and that's why they got into it. From a NorthStar perspective, we're really trying to look at what do the next 5-10 years look like in anesthesia, and how are we preparing our clinicians today to be prepared for what's out there?
Yeah, I think one of the things I've been most impressed by is the long-term strategy and thinking and support of NorthStar from Cranemere for us to really not look short-term in the next year or two. We really are truly looking out 5 to 10 years. And that means a lot to the clinician on the ground. The stability of that, especially in these times, I think has been very important. So just to take a little bit of a step back and hear more about your background and then how we're leading in the company, Adam, why don't you just tell us a little bit more about kind of where you've come from?
Sure. So I've spent 30 years now in the healthcare industry. Most of that time was at a company called the Advisory Board, where we really focus on issues that keep hospital CEOs, CXOs, COOs up at night. And we really tried to solve those, whether it was solving it through research, technology, or consulting. We helped them. And it's been a great background for this job, which was about a little over 6 years ago, was asked to come in and run NorthStar, because I understand to a very good degree what hospital executives are looking for in their anesthesia service. And I think that's been helpful context, because a lot of times it's, they're really the person who you're working for in some ways is the surgeons, and the hospital administration. So that background has been really helpful for me as I've sort of taken on this job.
Yeah, for sure. That lens, I'm sure, has been extremely helpful. Meagan, on the side of what you do, so tell us a little bit more about yourself and then your role within NorthStar.
Sure. I live in Washington, D.C. I've got 2 little girls who are 9 and 7. Hey, Sadie and Maggie. And so I have also, similar to Adam, been in healthcare my whole career. I started off actually just down the street from here in a cardiologist's office, and was kind of a jack of all trades. So I saw billing, I saw sort of patient engagement, helping the doctor prep for visits, also follow up. So kind of got the full scope of sort of what a patient experience is, and also what a clinician deals with every day, from the not just the clinical, but all of the administrative burden. And then I joined the advisory board and spent over a decade there, and actually prior to joining NorthStar officially, I actually worked with Cranemere directly. And so I can sort of attest to the long-term mentality, having been on that team, and was really excited when Adam asked me to join and become Chief Operating Officer in 2020, which was really exciting.
Oh, yes. What a great time for a job.
Yes, essentially my first month on the job, was March of 2020. And obviously, so many of our team members were impacted very directly. What did they say? Jumped into the deep end, so to speak.
That's it, quite honestly.
Yes, exactly. But in NorthStar, I'm responsible for our clinical recruiting team, many of whom are here, as well as our operations team. And they are sort of our business leader paired with our CRNA and physician anesthesiologist leaders, really kind of working with our teams as well as our facility administrators.
Yeah, so the model is really an integrated approach to how we partner with the facilities and systems by which we are affiliated with. And I think one thing that is unique is that our clinical leaders do have an opportunity to work hand in hand with operations and you in a lot of instances and learn a lot.
It's a really wonderful partnership because we are providing such a critical kind of patient care service that it doesn't make sense to not have our clinicians at the table in all of our conversations, whether that's working with an OR manager or working with the CEO of the facility. And it's been really fun to watch, especially some of our clinical leaders rise up through the ranks. The folks I used to work with when they were a chief and medical director, now running very large kind of systems. And so I've just appreciated their knowledge and the partnership. And we really do each bring something to the table that without it, we'd make a worse decision or we'd approach a situation in just a much poorer way.
Yeah. You talked about where you started in this cardiac office and having that experience with patients specifically. And I really feel like that is infused into how you lead.
Yeah, to me, I've worked in healthcare organizations that aren't direct patient care related. And what's so wonderful about NorthStar is what we do every day and the purpose behind it is so clear.
Yeah.
So at the end of the day, we need to take care of our patients well. And my job is to support our clinicians in doing that and support the facility in doing that, whether that's an ASC or hospital. And that needs to be paramount and front and center. And so while, yes, we have to worry about sort of the administrative processes or the financial sustainability to make sure we can keep doing that. But at the end of the day, if we've taken care of the patients well, that's the most important thing and the guiding light.
Yeah, absolutely. Josh,
Yes.
speaking of quality care for our patients and taking care of them, you wear many hats at NorthStar. So why don't you tell us a little bit about what you do?
Yeah. So a little bit about myself. I'm an anesthesiologist, Columbus, Ohio. I was on faculty at Ohio State for 5 years before joining NorthStar, mainly did thoracic and neuro anesthesia. Joined the company with an opportunity to be in a leadership position with some non-clinical allocation, and it has just kind of grown. And now I'm chief quality officer of the company, still practice anesthesia, but also drive our quality initiatives and some of our business development initiatives. Focused really on three main areas. I'm phenomenally passionate about the delivery of anesthesia. I just want to make sure that it is standardized across our footprint. Focus a lot on reporting our quality metrics to CMS and third-party payers, and then ensuring that every anesthetic that we do is safe. So really an ongoing effort to becoming a patient safety organization.
Yeah, absolutely. Well, let's dive into a little bit about what the weather is like here in the world of anesthesia, because a lot has changed post-COVID. There were some trends, I think, before going into the pandemic, but coming out of a lot of headwinds. Adam, I think we've talked a little bit about this on TopMedTalk, but why don't you kind of take us back a little bit where we've been in the last several years?
Yes, anesthesia was already a pretty tight labor market before
Mm-hmm.
what happened with COVID. And, it's sort of like as you go through kind of 2020, 2021, 2022, it's sort of like every year has another impact. The first thing was obviously a lot of physicians and CRNAs leaving the workforce during COVID, like happened everywhere else. And you already had a tight labor market. So that was pretty challenging when people were coming back. The next thing was because of the way that volume shifted during COVID, it accelerated a move from inpatient to outpatient surgeries. So you all of a sudden had a bunch of ambulatory surgery centers that were trying to work weekends, work extra rooms, work late at night, which required more anesthesia care. As hospitals came back online, they assumed the volumes were going to be the same as that were pre-COVID. So they start expanding their ORs, running late, running more rooms. And so you have this big expansion in demand that was not only exceeded our capacity, but also exceeded the volume capacities.
Yeah.
You may have had, a 3 or 4% increase in volume, but you had a 15 to 20% increase in capacity. And we as a profession have to cover all of that capacity, whether there's volume there or not. So that created another real strain on anesthesia, and that drove up labor costs. In a normal market, what you then do is say, hey, Blue Cross and Blue Shield, our costs are going up. We need to be reimbursed more because it costs a lot more to provide anesthesia than it used to be. And that's when the No Surprises Act happened. So basically, the No Surprises Act removed the ability for anesthesiologists and CRNAs to go out of network and take claims out of network. So that actually took away any stick from your payer negotiations. So now if we're talking to a payer, we say, hey, our costs have gone up. Can you pretty please give us more money? And shockingly, a lot of payers say no. So that actually has created this world where higher demand, which has driven higher labor costs without enough labor in the market while revenue is dropping. And that has really shifted a lot of the cost to the hospitals and increasingly ambulatory surgery centers to pay for anesthesia.
Yeah.
And that's kind of the world we're living in. Now, what I'd say probably across the last 18 months is things are getting a little bit better. Two things have been happening. One is that you're seeing more and more students hit the market. I think you're seeing some people return back because they can make a lot of money working part-time. And the other side of it is you're starting to see labor demand rationalization. So I think hospitals and ambulatory surgery centers are saying, gosh, why are we running on Saturdays when we don't have any cases anymore? This is expensive. Let's stop doing it. The hospitals are saying, gosh, we've been running these 3 extra rooms because we thought volume was going to come. It's now been 18 months. Volume hasn't come. Maybe we should just sort of call it. And that rationalization has helped as well. So I think you're seeing more supply, less demand. And it's just, I think from a provider perspective, I think it's helping a lot of our clinicians. Sort of the burnout, I think, is not as acute as we probably saw it 24 months ago.
Yeah, absolutely. For sure.
Yeah, no, I was just going to say, I mean, like a tangible example is a hospital that maybe has 4, or let's say 3 total joints, and they start their first total joint in room 1, and then at 9:30 they move to room 2 and do that second total joint, and that room has been vacant in the before, and it's going to be vacant after it, and they go back to room 1, and then they do that third total joint. In 2021, the ASC would have said, well, absolutely, we have to staff these 2 rooms. We have to keep this surgeon happy. And now the conversation is, this doesn't really make sense. And it certainly helps us to have a conversation with a client that is, to Adam's point, rational in how they are allocating really expensive resources.
Yeah. Josh, really quickly on this expansion that Adam mentioned, we're seeing a lot as a frontline clinicians, this expansion happening in non-operating room, different places. So NORA, as we like to call it.
Yeah.
How has that impacted us in the workforce?
I mean, it's out of OR spaces is the Wild West because there is 0 block scheduling. And maybe you're fortunate enough to have an Epic scheduling platform that will say out of OR is like OR 99. Yeah. And they say MRI gets 4 hours on Monday, and then IR gets 4 hours in the afternoon. But they don't even do that. I mean, inherently, out of OR is, for the most part, it's unpredictable because it's inpatients that come in with obstructive uropathy and haven't had an emergent PERCNEF, or, it's a patient that comes in with neurologic symptoms and has to have an emergent, like, head to sacrum MRI. So it's unpredictable. They tend to be urgent in nature. And then there's the other part, which is historically these were done with fentanyl and Versed with sedation nurses. And I'm not advocating that's the direction we need to go back to, but they were done that way previously. We sort of took over that area with, maybe we are doing conscious sedation, maybe we're doing MAC, maybe we're doing frank GAs, but that is never going to go back to sedation nurses. So
it's presumably safer that we were.
Presumably, right. Yes. But that is like the really incredibly difficult part about out of OR. It's just you have a labor resource which is occupied in IR and is basically working 4 hours during the day. They may be busy doing pre-ops and trying to facilitate getting this patient down from the ICU for whatever procedure they're having done. But the reality is, in terms of like work doing cases, it may be only 50% of the time that they're allocated to that space, to that area.
Meagan, you're shaking your head here. So what are these conversations that we're having with our partners?
Yeah, I will kind of echo where Adam said, I think a lot of our facilities that we work with are having their surgical spaces really demand rationalized, and they understand it. And they're actually doing a lot of interesting work to figure out what service lines do they want to grow and rationalize even maybe across the system what they're doing at each facility. But Josh is totally right. Nora, they have very little visibility into. They don't have a sense for scheduling practices. They really don't have the same management structures. Oftentimes they'll report up through a department head, not a surgical head.
Yeah.
And so for them, it's actually very difficult of a problem to crack because they don't know if the resources are really needed or not. And so oftentimes we're shedding light that it is a problem first and foremost. And then we do try to talk through what are ways you can actually just give everybody visibility into what's happening, whether it's putting it on the SNAP board or even changing some management structure. So a surgical service lead also has visibility into whether it's MRI or IR or what have you. But we do talk about, hey, this is an increasing cost, and 50% of this just our resources being expended in probably a less efficient manner. In addition, you have lots of other staff supporting that procedure that also is presumably not well used.
Yes.
So what would you like to do about it? And typically we sort of try to start with, let's break down the problem a little bit, maybe tackle one service line and then the other, because otherwise they can easily get overwhelmed with how to, again, kind of make it all more efficient.
The only other thing I was just going to add is I think there's also just kind of a little bit of a lack of understanding amongst non-surgeons of like what anesthesia is. Just as an example, anecdote, I'm called to the MRI suite. Patient has received now 6 of Versed, is oversedated, but also agitated. Sats are going down. Decision, induce anesthesia. But, I'm not putting a quarter in the anesthesia machine. Like, I'm here now for the rest of this case. It would have been much better if you had either scheduled this or used appropriate sedation.
So, for sure. So, all of these are challenges that we're facing. And I think, Adam, you mentioned the workforce and how, that has also been kind of an uphill battle. Transition between full-time employees of traditional groups versus the migration towards locum tenens. And we've, again, had multiple conversations about that. Where do you think the wind is going now? How is that moving and shifting?
Yeah, I do think you're starting to see kind of and again, it's a little bit different for the physicians and the CRNAs, but I think you're starting to see the locum stuff come back a little bit. It is, as opposed to everywhere is a problem, you now have localized problems.
Mm-hmm.
So there are markets where oftentimes you'll see maybe a big system will decide, hey, I'm going to insource overnight. And now all of a sudden rates go up like crazy and everybody says, oh, look, I can go locum and make a lot of money for a little while. So they tend to be, specific metro markets. They tend to be time delimited, as opposed to, I would say 3 years ago, every facility in every market was having this problem.
Yeah.
So I think, again, it's not solved. But, at the end of the day, most of our teams don't love locums because they're not a team member. They don't understand always what the hospital's procedures are. They don't know what the team's procedures are. It's hard to create a culture when you've got new people rotating through. So, we really do try to figure out ways to avoid locum usage when we can. But you do have to balance that with, work life, which is, look, you don't want to burn out your own team. And sometimes locums are needed in order to avoid that burnout. So it's a balance that we look at market by market, facility by facility. But I'd say the trend generally is headed in what we would say is the right direction, which is less locum utilization.
I would just also add, and this is an area that I think Meagan's team has done a tremendous job, is there was a reason that a lot of people were going into locum tenens, whether that was financially or it was they liked being able to work 3 weeks on and have 1 week off, or they liked 50-50 or whatever it was. So we have gotten a lot more creative in how we pro forma models to sort of say, okay, that was an itch that was scratched by being a locum tenens. Can we offer something similar to that to say, yeah, we may have drawn this up in the sand to say you're going to work as a 1.0 FTE and have 10 weeks PTO. But the reality is we may not be able to find folks to fill that. But there are a lot of folks that maybe want to work as a 0.4 or 0.5 or a 0.6. And so we have adapted our employment models to be more attractive to that work-life balance that Adam spoke about. That was met and satisfied by being a locum tenens, but now maybe we can just create a model that satisfies that individual, and they just join our team whole hog.
Yeah, I love
Couldn't
the
agree
energy.
more. Yeah, it just and that's been a real partnership between our clinical leaders, our recruiting team, and our operations team. The idea that you could almost have sort of 4 different jobs, quote unquote, at a single place. They're just working a different schedule. I think it's really also helped us with working parents.
Absolutely.
So you can, have a no-call job, or you can have your call structured in a certain way, or you can work 1 week on, 1 week off. Those kinds of things just allow us to include many more people who previously may have chosen a PRN or a locum position for that flexibility. And, again, as a working mother myself, it's great to be able to
Absolutely.
offer different structures, because that's, again, what really keeps more folks working, talented clinicians that we all need working with us in new and creative ways.
Yeah, and have that personal satisfaction and professional balancing out. That's one of the things I felt one of the strategies that we have really employed to try and bring and recruit into our organization. I think the other big piece that I love to talk about, because I'm an example of that myself and Joshua as well, is the opportunity for us to grow professionally and grow within the leadership of our company. I don't know if that's something that we can do everywhere, but I never even imagined when I started as a CRNA that I had an option for this. So talk to us a little bit about that. And Josh, from your experience, I'll start with you kind of.
I mean, that's the reason I joined NorthStar 10 years ago was, right, I was in an academic department, really good clinician, but that was what I was seen as. You are a grinder in the operating room. You may have aspirations for leadership, but you don't have the requisite numbers of publications. You don't have the number of years on the bench here at the university. So we're not going to put you up for promotion and tenure. For us, what makes the contract the stickiest is having a strong leader. And so the reality is that is how we survive as a company, is getting contracts, holding contracts, and making contracts successful. And the way you do that is with a strong medical director and a strong chief CRNA. And if that is inherently what holds the contract, you need to invest in leadership, whether that's clinical operational leadership or clinical quality leadership. But you have to create a pathway to grow people, to give them the professional satisfaction, but it also benefits NorthStar from the standpoint of, we know that that contract is set because we have a great leader in place that can answer the questions for the surgeons, that can help onboard new clinicians, that can help as an ambassador and a recruiter, and frankly has a really tight relationship with the C-suite at the local level.
Yeah. I mean, Adam, from your perspective, leading our organization, this seems to be a priority that we continue to kind of go all in on.
Yeah, I mean, this is a huge thing for us, and it's something that, we really focused on early on, which again, when you're looking sort of farther out, this whole concept of like, nobody cares who Adam Spiegel is.
Yeah.
Like, I'm not going to work at a facility because, boy, there's a fantastic CEO of NorthStar, or that it's a NorthStar facility at all. They're going to work and stay at that facility because the medical director and the chief that are there are people who have created a good culture, that are reasonable, that people like to work with. And that's the key to our long-term success, is if every one of our medical directors and chiefs are really strong, we're going to have great culture and ultimately take care of our patients better than everybody else. So how do you create that? One is you obviously have to invest in your existing leaders, but then you have to create opportunities for new leaders because people retire, people move. How do you keep that pipeline of good leaders there? And, the world has changed. We realized, in the last 12 months, we have a bunch of people in leadership roles who don't know what it was like before COVID.
Oh my
Yeah.
gosh.
So
Yeah.
if you think about it, we've got medical directors and chiefs who, may have entered the workforce or, finished their residencies around COVID. And those people don't know what it's like to have a full staff.
Yeah.
And
Oh,
how do you manage a team that's like entirely yours? And so as we think about training our executives, it is an ongoing journey in terms of, hey, how do we get strong leaders in place and equip them with all that they need to do to be effective leaders, evaluate them, give them ongoing training, give them feedback so that they can continue to improve.
yeah. Megan, it's really exciting.
It is. And the other thing I would say is we've tried to create, I think, some more on-ramps into leadership, so that it isn't, maybe not quite Josh's scenario where the, time and seat is important. But if you have a great medical director, and you really want an anesthesiologist leadership position that might not be available at your organization, I think what we're trying to do is create assistant positions or folks who really lead recruitment for that facility or the schedule. And so give folks a flavor of what the skills are that they'll need to have when they are, a full medical director or even sort of continue to advance beyond that. And I think that's been helpful also for some groups where maybe, I think oftentimes women don't raise their hand for positions. And
Exactly.
so to give them some exposure and experience to say, no, you can actually do facets of this job. And so then when the position does become available somewhere, they're eager to raise their hand and confident going into that new role.
And then speaking what we were talking about earlier about the flexibility and different modeling of leadership, I think that's going to be really important as well.
Yeah, and I think I would just also add that our executive team and our sort of VP level and regional leaders, to Megan's point, they know what it takes to be a good leader. So they can find, ideally, women that might be uncomfortable. Anyone who's uncomfortable raising their hand, oftentimes you ask for a leader and the people that raise their hand, you're like, ooh, I don't know if you're the right person for this job. But they can see folks and
Yeah.
say, you know what, we need to dive into this person and give them the training and obviously the confidence to say, you got all the skills. You may not see yourself in this, but you've got all the skills to succeed in this role.
Yeah, tapping them on the shoulder to say, have you ever thought about
Yes.
that? That's really,
Or arm twist and say,
yeah.
I'm telling you to think about.
Did you need to do this? Well, wrapping up, guys, I appreciate you all coming on and talking with us at TopMedTalk, and I appreciate the support for me to continue to do this. There's a lot to be there was a lot to be a little bit frustrated with, and a bit of a Debbie Downer on some of the things that have happened in the past. Going forward, I feel like there's a lot of optimism. I feel like we're the tides are changing a little bit. Adam, from your perspective, what would you say you're most optimistic about?
For me, I'm most optimistic about, honestly, this conversation we've just had, which is around leadership. I think, every year we bring all of our leaders together at an annual conference, and I find that every year I go there, the feedback and the people are happier.
Yeah.
And it's like, hey, like I'm staffed. Like, boy, I like what I'm doing. Here's what I found value in. And I think you're starting to see that a lot of these facilities that were in a not great place with the right leaders in place, with the right support, are turning that around. And I think for me, there's a lot more facilities that are turning it around and headed in the positive direction than facilities who are not going the other direction. And I think you're not going to win everywhere, but that's a lot different than the world felt 2 or 3 years ago. And that's what I'm probably most excited about as you start to see these people winning again. I think everybody's happy about that.
That's a good way to put that. Meagan, how are you from an operations standpoint and supporting our teams?
Yeah, I would say I think some of the conversations we've had to have over the years with our facility partners, and they've been hard. When you're sort of seeing compensation rise, 20, 30, 40%, our reimbursement declining, it's a really tough conversation. I feel like now they're much more oriented around partnership. We have a much more engaged staff, much less temporary clinicians on our teams, and really strong leaders. And we're doing a lot more to show our value. How are we shining a light on Nora poor utilization? How are we talking about our ability to support surgeons better with new innovative techniques, things like that? And again, so the conversations just feel more positive and partnership oriented than I need you to urgently solve a really
Right.
hefty price tag problem.
Yeah.
And that's just a much better place to be.
Yeah, absolutely. And Josh?
I mean, I think what makes us as clinicians good at our jobs is we handle what is happening in the here and now really well. And we might think maybe a week in the future where a surgeon comes up and says, hey, I've got a patient with a difficult airway who's going to be coming in. Let's make sure we got everything ready, or we have this strange tumor dissection that's going to be coming in 2 weeks. Let's make sure our I's are dotted and our T's are crossed. But for the most part, like planning stops 2 weeks in the future. Not brown nosing my CEO and my COO. But where I am like very bullish on NorthStar is Adam and Meagan have 1 year, 3 year, 5-year plans. It's not like, oh, hey, next quarter we're gonna do great. It is next year we need to be here. 3 years from now, our plan is growth X. Our clinical goals are Y. 5 years as a company, we are going to be accomplishing XYZ. That is very comforting for me, who has a long-term goal of still being with the company, of like, oh yeah, we're going to continue to be very successful in the future, because we've got people who are planning that.
Yeah, absolutely. Guys, fantastic conversation. Thanks for doing it. I appreciate it. More to come from Anesthesiology 2024. You can always find TopMedTalk at TopMedTalk.com. We're on all your favorite social media platforms: X, LinkedIn, Facebook, YouTube. We're there. If you found us on YouTube, give us a thumbs up, subscribe. Every little bit helps us here. You can find more conversations like this, more with Adam and Josh at TopMedTalk.com. Be sure to check those out and all the great content from Anesthesiology. Thanks so much for listening. Bye.
Thanks.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is epom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. epom.org.